To the afternoon session. We're going to pick up with an additional set of speakers. Our first speaker this afternoon is going to be Dr. Thornton.
Hello there, everyone. Let me share my screen so we can. So hopefully you can all hear and see me. Good afternoon or good morning, depending on where you are actually sitting down and watching this wonderful conference. Thank you to the organizers and everyone involved in EHE 360 conference for inviting me to come speak to you on a subject near and dear to my heart. I wish we were all in a room together where I could see all of your faces, but we will have to look forward to that in the years to come. When we discuss multidisciplinary care, we generally are thinking about medical oncologists, radiation oncologists, and surgeons working together for the greater good of our patients. I want to focus a bit on another multidisciplinary team that is helping to further the care of an at-risk, vulnerable patient population that is often not recognized as such. But first, I want to highlight a patient of mine that we will come back to towards the end of the discussion. Angela, and I've changed her name for patient anonymity, is a lovely young 35-year-old patient of mine who was involved in a car collision. She was not badly injured, but out of an abundance of caution, she was brought to her local emergency department and had some imaging performed to rule out fractures and internal bleeding. Although she did not have any internal injuries from the car accident, she was, to the surprise of the ER physicians, noted to have multiple scattered pulmonary nodules and liver nodules. These were then biopsied. The pathologists were stumped by what they were seeing, so her tissue was sent to Memorial Sloan Kettering and found to be consistent with epithelioid hemangioendothelioma. After she healed up from her scrapes and bruises, she was completely asymptomatic, but was now faced with the daunting aspects of her new diagnosis. So remember Angela, and we will come back to her later on in the discussion. As way of some background, why exactly am I talking about AYA as a vulnerable patient population? First, let me define what AYA means. AYA, or adolescent and young adult patients, are defined by the National Cancer Institute as those patients between the ages of 15 and 39. As you have all heard from several previous speakers, and as you probably know, as this may reflect your own situation, the median age of onset of EHE in one series was about 36 years old, and in another series, 50% of patients were under the age of 50, right within that AYA age group. Advancements in AYA for AYA patients have significantly lagged behind those of their adult counterparts. Archie Blyer is a pediatric oncologist who is a pioneer in AYA research. In the mid-2000s, he and several colleagues published some seminal papers on the poorer outcomes in the AYA age group. There are two graphs that visually highlight the disparities in clinical trial enrollment and survival in AYAs. The graph on the left shows the age at entry into clinical trials. And as you can see, for the AYA patient group, the numbers far are less than their pediatric and older adult counterparts. And even more shocking is the graph on the right, which shows the survival in the AYA patient range, which is actually decreasing rather than increasing in that AYA range. So we need to make a change. Why the disparity? There are many reasons for this. First, there are patient-level barriers to care. Patients in the prime of their lives with busy work schedules, dependent on working for insurance, caring for their families, with no time to take care of themselves. There's difficulties traveling to specialty care centers, and for those oftentimes rare diseases where they need to do just that. There's more denial, both on the physician side and the patient side. Younger people are usually young and healthy. They are often diagnosed later in their disease course, as several signs and symptoms might be mistaken as other issues like sports injuries. There are physician-level barriers. Physicians unfamiliar with certain rare tumors that are more common in the AYA population. Time. In a world where many patients are rushed in and rushed out, the complicated needs of the AYA patient are hard to meet. Addressing sexual dysfunction, fertility preservation, the complex psychosocial needs of our younger patients along with grappling with the diagnosis, is a challenge at best when confronted with the small time slots in which to see patients. There are institutional level barriers, which are some of the most frustrating for me to hear about, because I feel that they're oftentimes very surmountable. At times, there's no partnership between the different departments in best caring for the diseases that are more common in a younger age population. Institutional IRBs or research committees may not have pediatric representation, which is vital in lending a voice to the issues that pertain to younger patients. Pharmacies may be separate for the pediatric side of an institution and an adult side, making clinical trial collaboration challenging. And lastly, and the barrier I've been very fortunate to be involved in trying to chip away at over the last several years with the American Academy of Cancer Research and the FDA, are the regulatory barriers to enrolling all ages onto clinical trials, the true path towards developing novel therapies which will ultimately lead to prolonging the lives of patients and improving quality of life. So at my institution, Memorial Sloan Kettering, following the lead of pioneers like Dr. Bleier, some passionate people got together to try to change the current state of affairs. The MSK-AYA program was formed, and within our sarcoma division, we formed the AYA Sarcoma Treatment Paradigm Working Group. We developed our goals and missions and set out to try to harmonize our approach to caring for AYA patients across the institution as a whole. With cross-institutional collaboration and tackling one disease state at a time, we are developing unified order sets and treatment algorithms. So no matter whether you come in through the door on the pediatric side or the adult medical oncology side, you will be receiving a unified treatment with unified access to resources. Between the different facets of our working group, we meet weekly, both to pave the path forward and unify approaches, but also to discuss our patients and review current and upcoming clinical trials. The MSK Sarcoma Working Group is a beautiful example of what it means to be multidisciplinary. The core group formed with collaboration from amongst pediatric oncology, medical oncology, pharmacy, social work, and nursing. But of course, it doesn't stop there. As part of our AYA team as a whole, we have representation from oncofertility, oncocardiology, nutrition, hospital administration, data coordination, psycho-oncology, pharmacy and therapeutics, physical therapy, occupational therapy, and most importantly, survivorship, so that the changes implemented can be instituted and formalized within our institution as a whole. So back to Angela. How does this all come down to the patient before me in clinic? Well, in Angela's case, she was able to come and see us for consultation. Chemotherapy had actually been recommended by her local oncologist, but we suggested we take an initial watchful waiting approach, which proved to be very successful in Angela's case. We were able to enroll her in our IMPACT trial for genomic evaluation. We had social work reach out to her to discuss ways to discuss her illness with her kids and her family, and connected her with our AYA nurse navigator, who was able to align her with several of the AYA-focused patient groups. She was able to connect with our integrative medicine team to discuss some alternative and complementary care questions she had. And she was reassured that if she need to venture into research or treatment, she has the ability to meet with our oncofertility team. Hopefully, through working with our AYA multidisciplinary partners, she has the support network to help her with not only the medical challenges, but the psychosocial ones as well. And as for future directions for our group, other AYA working groups are being initiated within other oncology specialties across the AYA age range, like genitourinary oncology, which encompasses testicular cancer, hematologic malignancies addressing things like lymphoma and leukemia, and neuro-oncology addressing brain tumors and diseases like neurofibromatosis, which afflict a younger patient population. Additionally, we want to make sure that all the efforts that we are doing are creating a positive impact for patients. So evaluating outcomes to and after treatment harmonization will be vital to our mission. In conclusion, everyone wants better outcomes for AYA patients. We all want better outcomes for all of our patients. AYA treatment harmonization is crucial to improve outcomes for one of our most vulnerable patient populations. Current guidelines and FDA guidance allow for the incorporation of patients, both young and old, into clinical trials if scientific rationale exists. So we should really be pushing our regulatory authorities to make sure that this happens. And institutions that care for AYA patients should implement an AYA task force or working group to chip away at the existing barriers that impede care. And with that, I'd like to acknowledge my MSK AYA sarcoma working group members listed here, but most importantly, all of our patients who inspire us to push the boundaries and to work to developing better treatments and hopefully ultimately a cure. Thank you.
Thank you much for that presentation. Our next speaker will be Dr. Okuno.
Well, thank you all for the invitation here to speak a little bit about coordination of community oncologists and large academic medical centers. I'd also like to thank the organizers for this opportunity, and specifically you all for being here today and learning and sharing all the stories that we have. To remind us, it's all about the patient. It's all about you. Back in 2012, an individual did present with some pain in the right buttock and was found to have this lesion along the right iliac region there, or right ischial region. An MRI was performed, and you can see there that there was this area along the right area that was quite localized. And then the question is what to do about it. This was back in 2012. And if we fast forward to 2021, you can see that that tumor was surgically resected, and that individual is now almost 10 plus years out without evidence of recurrence. And it was because of her ability to get to an academic center that allowed her to have a pretty aggressive surgery, but a curative intense surgery. And at this point, this is why you and all of us have to get to academic sites for this. But there are some challenges getting to academic sites. The first challenge that we do see is that it's time. For many of us, leaving work, having our loved ones come with us, go to an academic center does take time and logistics. We also, and should not underestimate the cost of actually going to an academic site, traveling either by car, train, plane, the hotel night if need be, there is that. In addition, the distance is quite alarming, especially in the United States, but we have to realize that distances are also a key factor of the potential barriers to getting to academic sites. In Europe and UK, it's probably pretty easy. Now, speaking from someone here from Minnesota, you have to realize is that everything is far from Minnesota, but in the UK and Europe, everything is pretty dense. Now, it's a little bit difficult to travel to different areas, but you can see the density of the population is pretty tight. However, if you look at the United States, the density is mostly in the coastal areas, and there's very, very few density of patients in the Midwest/Western part of the United States. And if you happen to have an unusual tumor that does need expert opinion at a tertiary care, distances, time, and money is a factor. Well, how do we figure out where to go? I think that's the number one thing. And typically in the United States, we look towards the NCI designated cancer centers. Makes sense. However, there are 71 of them. Some are cancer centers, some are comprehensive cancer centers, and some are basic laboratory areas. But once again, these are strategically located in high density areas. So if you don't live in an area, how do you get to that? So one of the things we realize is that COVID, although it's quite devastating, might actually be a blessing. It's really jumpstart all of us to use telemedicine. By having telemedicine, potentially the distances are solved. Potentially the cost of the patient and you all to get off of work, have your loved one get off of work and fly, hotels, et cetera, could be definitely decreased. However, we as an academic center have very little infrastructure in the past to handle this telemedicine. However, we've been able to jumpstart this pretty quickly here with the advent of COVID. In the United States, I think legislatively as well, I know we heard earlier on that Dr. Rubin and Dr. Jones don't want to lose their licenses for doing things that they shouldn't do. But typically in the United States, you are licensed to practice medicine in the state for which you have your license. However, in 2022 and in 2020 and 2021, the federal government did release a federal public emergency update that does allow physicians to practice across state lines for coverage of telemedicine. These emergency acts keep getting updated each month or every quarter or so, and the most recent one just came out, extending it through April of 2022. Many of us want to see this continue on, and your help in supporting this will go on because it does help the barriers to getting to academic medical centers. We also have to think back a long time ago that when we were trying to do high jumping, the only way we would do high jumping is to do it like this young gentleman on the left. It was only when you thought of new ways of doing things through the Fosbury flop that the records of the high bar have actually gone significantly higher. And it's that thinking differently and being able to be proactive and think about that that has allowed us to improve our ability to reach more patients and to allow patients to stay at home as best they can. Clearly, there's a cost of oncology care for all of us, and that's pushed back to the patient as well. And we have to remember, we're all in it for you, not necessarily for us. So at Mayo Clinic, we do have an outpatient telemedicine service, and we do provide oncology consultative services all across the United States and certain collaborations outside of the United States through a video technology aspect. One thing that's quite unique is that most of the centers that do have the ability to do telemedicine are the academic centers as well. And we hope that many of you are able to take advantage of that. The advantages that we see about telemedicine is that your slides can be sent here to an academic center. The images are all electronically captured and can be pushed and viewed and formally reviewed here. And we then can actually engage with you without masks. Because if you came to Mayo Clinic, I would have to be wearing a mask. I'd have to wear goggles. You would have maybe only one visitor, maybe no visitors, depending on the COVID surge at that time. But the ability to kind of reflect, have multiple people across your family on the conference call is greatly appreciated. And we can actually get expert review and recommendations. And then we can then connect with patients and your local provider at home. So I do think that this is a unique experiment, as we would say, due to COVID. However, we're really hoping that this will continue to last into the future. And I think it will be something important, especially for EHE, where it's so rare and the ability to come out is difficult. So with that, we appreciate your time and effort here, and we look forward to further discussions.
Thank you much for your presentation, Dr. Okuno. And our next presenters will be a duo, trying something new here, Dr. Vesel and Emma Ernst.
Good afternoon from cold weather here in Boston. We are in the middle of a snowstorm. Thank you so much for inviting us to EHE International Conference. We are delighted to share our thoughts about pain management in patients with EHE. And my name is Tamara Vesel. I'm a chief of palliative care physician. I'm a chief of palliative care at Tufts Medical Center and Tufts University School of Medicine.
And my name is Emma, and I'm a fourth-year medical student at Tufts.
Thank you, Emma, for sharing this presentation with me. What we are hoping to do is to talk a little bit about pain that unfortunately is one of the features of EHE. And what we are hoping to convey, the main message is that pain is complex and the approaches should be multifactorial. Pain starts somewhere in the tumor level in a periphery, and there are multiple medications, but many other modalities. So the main message is we would never give up on pain management.
So just as some background, pain is a common symptom in cancer generally. Somewhere around 30 to 50% of people with cancer experience moderate to severe pain that can negatively impact their quality of life. And EHE-related pain can be severe and difficult to manage. Unfortunately, there are relatively few studies looking at the sources of EHE-related pain and what some of the most effective treatment options are for pain in EHE. So I'll start off by talking about giving an overview of some pharmacologic interventions, and then Dr. Vesel will talk more about other approaches to pain. To start off with, non-steroidal anti-inflammatories, or NSAIDs, are a type of pain medication that most people are already familiar with. Things like ibuprofen can be bought over the counter. They function to help reduce pain as well as reduce inflammation and lower fevers. And they're typically used for moderate to severe cancer pain. Side effects can include gastrointestinal irritation or bleeding, kidney disturbances, cardiovascular complications. And clinical experience has suggested that EHE patients in particular may respond particularly well to NSAIDs. Unfortunately, though, like I mentioned, hasn't been well studied, and it's not entirely clear why that might be. It's possible that there'll be more of an inflammatory component of EHE relative to other cancers. Opioids are another type of pain medication that's commonly used for cancer. This is more for moderate to severe pain. Examples would include oxycodone, morphine, hydromorphone, methadone. The opioids work by helping to block some of in the periphery, block reception of pain, and side effects can include constipation, nausea, vomiting, as well as drowsiness or sleepiness. There are also many other types of pain medications. Some of these were originally developed for other purposes. So for instance, there are antidepressant medications such as duloxetine, amitriptyline that can be helpful for pain. There are drugs that have been used to treat epilepsy that are also helpful for pain, so gabapentin as an example. And then there are other types of drugs like ketamine, muscle relaxants, steroids as well. To point out one example, steroids help reduce inflammation. So that would, helps to function to kind of reduce pain at the source. And then some other pain interventions include nerve blocks, where there's injection of a local anesthetic around a nerve to help block the perception of pain. Intrathecal drug delivery is when pain medications are delivered to the spinal cord, which can help kind of deliver the drug more directly and can mean sometimes that you don't need to use as high doses of those drugs. And then palliative radiation is radiation therapy that is used with the intention of reducing pain rather than, for example, curing a disease.
Thank you, Emma. I would like to devote this portion of my presentation to a patient of mine who asked us to write her case report, which Emma helped us with, to Kate, who I got to know during her journey with EHE and severe intractable pain that I learned the most of. And her family is very aware that we are presenting it today and feel very honored that Kate continues teaching as her legacy. There are many non-pharmacological interventions that actually affect mainly up there in the central cortex or thalamus, which I think are very, very important. And I would like to lead us through a few of them. Obviously, with a short time of presentation, we won't be able to go to the details. My patient, Kate, actually got involved in multiple interventions, and she became a very avid meditator. We learned together hypnosis and self-hypnosis. She did do Reiki. She clearly was interested in ego strengthening technique and exercise, and as well exploring her spirituality. But what we worked on a lot throughout her illness was identity. My experience as a clinician is that when we walk through the world healthy, or we think we have an impression we are healthy, we identify as healthy people. But when we are diagnosed with an illness like cancer or EHE, we need to process who we are. And I think that's very important because it relates to symptoms as well. How am I related to cancer? What cancer means to me? How much threat I feel when I am diagnosed with cancer? And what is the role of my mind and my body and how they are related are the topics that we work through multiple different sessions with our patients. Next, please. That relates to pain. You know, what pain means to me, how I grew up, how my parents handled when I was in pain. What is the culture I am from? What part of descendants of what part of the world where sometimes pain means I'm weak or pain means I'm strong, and what kind of attitude I relate to when I have pain, and then how pain relates to suffering in my personhood. And then very clearly, it's very important with your clinicians to work out what is the goal and is the goal realistic? Is it possible to get the pain to 0? Or should we be aiming at the function and have a pain at 2 to 3 out of 10? Because that's where I'm not sedated, but I'm able to function and do daily chores. I would like to spend a minute or so on one of the techniques that we have been using with patients over decades, children, young adults, and adults as well. And it's hypnosis or hypnosis type of, self-hypnosis type of interventions for patients. Hypnosis gets kind of a funny press in movies and books that it's somebody else who is managing your brain. It's actually the other way around. Medical hypnosis is a state of focused attention when the patient learns to be more self-efficacious, to become active participant and find a solution during the illness and solve the problem instead of being a passive recipient of healthcare system. That leads into the ego strengthening and how we can engage instead of weakening ego of the person who is ill, strengthening it. And there are multiple techniques that patients get involved and learn. The other part that's important in training of hypnosis and self-hypnosis is finding comfort in some previous pleasant experiences. We are living in a very rushed society where we are moving forward and always thinking ahead, and we don't realize that there is a lot of comfort in recollecting in a moment of pain or some other needs, an experience from the past that may take over this central upper cortex and perhaps suppress the brain perception of pain while we are waiting for the medications to kick in. I'm not saying that this is a solution to pain. I'm saying that this is an addition to the pain control that the patients can learn. And there are some specific pain techniques, which is a double screen technique or a pain switch that we together partner with patients with severe intractable pain. What about meditation? I will very briefly mention that it is hard to learn to meditate daily when you already are diagnosed with cancer. So there are specific techniques instead of just sitting down and sitting for 20 minutes, because if you're in an acute pain, this is a task that is challenging. But we all have some meditative habits that we can actually strengthen during treatment of cancer or during pain related to EHE. That could be a walking meditation, walking through the forest, for example, forest bathing, or learning how to live with pain, which is one of the meditative Tibetan technique of living with a beautiful monster. Or simply doing what I learned from patients who were in severe pain. Take one breath at a time, to take one breath and not to think about 2 or 3 because it's too complicated. But in a pain crisis, breathe one breath at a time. Very simple but powerful technique for acute pain crisis. This is just a very quick journey of pain management in EHE. We never stop exploring different techniques for pain management, and our goal is that patients can live with the best quality of life, despite that EHE, most of the patients are experiencing pain. Thank you so much for your interest and for inviting us to this conference.
Thank you much for the presentation. If the two of you can please stick around, and we'll invite back Dr. Okuno and Dr. Thornton for a Q&A session. And we've got several questions that have come in. A number of them are sort of directed to individuals, so let's start with those. Dr. Thornton first. What are some things that patients can do to improve their own outcomes as AYA patients?
I think that it's a great question. I think one of the most important things that people, sometimes it's very difficult, but they have to learn is, how to be a good advocate for yourself. And, I think that, there is traditionally a culture of, you go to the doctor tells you what to do and you do it. But, that's no longer the case. People really need to work together. And I find it very, very helpful when my patient sort of writes up a list of the things that they want to address at each appointment and maybe sends it to us. As Dr. Okuno alluded to, a lot of our computer programs now have portals where people can send something to us ahead of time. And that really helps me address all of the things that is really important to my patient at that time and economize time.
Excellent, great advice, thank you. Dr. Okuno, a few questions for you. The first one is kind of a definitional question for you. What is the difference between a cancer center and a comprehensive cancer center?
I wouldn't worry too much about that, but that's a good question. A comprehensive cancer center is an NCI designation, and there's certain criteria for that. Your local community might have a cancer center, and that cancer center might be called a cancer center in your community. And generally, most of those cancer centers in the community might be a group of oncologists, maybe some radiation oncologists that got together and called themselves a cancer center. So you have to kind of know for sure what the terminology means. The slide that I showed you is on the NCI website, and they'll just specifically tell you which sites are the NCI designated cancer centers and comprehensive cancer centers.
For a couple of follow-up questions for you on some of the materials you presented. So some of the challenges cancer patients have in general, but EHE in particular, because it's a rarer cancer and many clinicians don't have as much experience with it, is what to do with mixed advice or alternative advice from different doctors. And the specific example raised in the question was, imagine your oncologist suggests that you go into watch and wait, but your liver specialist advises you to get a transplant. So sort of more globally, how does a patient sort of navigate modern systems like this and dealing with two different voices?
That's an excellent question, and we struggle with this every day. Dr. Thornton talked about it in her presentation, as well as the local doctor kind of suggested go at it with systemic therapy up front, whereas we might recommend a watchful waiting approach. We can also say in general that, you know, where we are, we have 4 medical oncologists. You know, we review the cases every week, we discuss it amongst ourselves, and that's pretty good. But there might be differences of opinions of what to do, even with our sarcoma group experts. And I can assume that might happen at other medical institutions. However, the other aspect is now we're working with community oncologists. And if we're recommending a watchful wait, but the local oncologist might recommend aggressive systemic therapy up front, I think you're going to then, as a patient, have to navigate that and really say, well, Mayo Clinic or Memorial Sloan Kettering or, you know, any other, you know, Cleveland Clinic recommended X, Y, and Z. And then we generally, most of the academic centers have great relationships with the community oncologists, and the vast majority of them will, after discussion behind the scenes, professional can come up with it. So we would encourage that rather than you get into fighting war with your local oncologist. Just say, hey guys, pick up the phone, connect with the guys at the academic sites that are making this recommendation, and we might be able to have some dialogue, and there might be different reasons that we might have missed that they're recommending treatment. So it's a two-way street. Dr. Thornton, any additional thoughts on that?
No, I think that's exactly right. You know, I can't even recall a time where, you know, we've made a recommendation and, you know, I call, you know, the patient's other outside oncologist and there's a battle. You know, usually we come to a meeting of the minds and, you know, fortunately, even though something like EHE is super rare, there have been some small studies that sort of, you know, kind of lead some guidance as to, you know, what is the best practice. And so, you know, we turn to the data to help guide us. So I agree with everything that you said.
Well, a somewhat related question for both Dr. Thornton and Dr. Okuno. Let's say a patient is recently diagnosed with EHE. An immediate question they're going to have is, what's the best treatment for me? And I know that's a complicated question because oftentimes the answer is it depends. But how do you address sort of that patient coming in the door with a new diagnosis and having a lot of questions about what the options are, especially since we're learning so much in real time here?
Scott, I'll tackle this first. You know, I think that you know, I think the overall arching theme of this part of our discussions today is multidisciplinary care. And, you know, when someone comes to me fresh with a new diagnosis, you know, some of the things that we're initially doing is, as Dr. Okuno alluded to, you know, we have a multidisciplinary tumor board that meets, you know, on a weekly basis. And, you know, we get all of the information, the scans, the pathology report. One of the things that most of, you know, especially when we're talking about EHE and a sarcoma treatment center will do, is we make sure to review the pathology. Because of the rarity of these diagnoses, you know, well-meaning pathologists in the community will, you know, get the diagnosis wrong. And we've done retrospective studies where we ended up changing the diagnosis in up to 25% of patients. So, you know, that's obviously a very significant number. So, you know, getting together, talking with our colleagues, you know, I mentioned the watchful waiting approach, which obviously can be really, really hard for patients because, you know, you've told you have this cancer and you want to just jump on it and treat it. But having some succession of scans so that we can see, wow, this is really, really indolent or slow growing. And, you know, it's staying steady. So we don't have to use up all of our bridges right now. We don't want to burn them. You know, we want to keep them in our back pocket for when we need them. So those are some of the strategies that we use to tackle a new diagnosis. I don't know if Dr. Okuno has some other thoughts.
Well, I would just follow up on that is one of the things is when you come to a major center, it's not just one person making the decision. Generally, as you're starting to hear is we share the case around. We might not be privy to, interventional radiology, radiation oncology, surgical approaches, because there is a huge amount of literature, although the community is quite tight knit. All of us have experiences that might weigh in, and you actually will benefit from that. But basically, it's correct. You have to kind of, and it's not unique to EHE. It's the same thing we do for every single cancer patient is to say is, what do we have? What are our options? And what are your goals personally as well? Because if you're truly symptomatic and needing treatment, some people elect not to do treatment because their goals in life are different. And we're not going to force that. So I think finding a center that has more of the getting the input of the patient and the family, as well as the expertise that surrounds that individual is the key part in helping making the appropriate decision as well on treatment.
And one more kind of question that just came in related to this that gets a little bit more into the weeds, but I think it's an important question. There's been a lot of questions about watch and wait versus alternatives. And this one's more specifically, if you have some indication of aggressive cancer, you're showing METs, are there scenarios where watch and wait is still appropriate?
Yeah, that's a good question. And it's the nerve wracking, even though you might see some growth, you'd like to really say is that it took a year for that growth to occur. We, as providers, an oncology provider might say, yeah, it's slowly growing, that's okay. But we know that in your mind, it's growing, it's spreading every day. I'm not doing something that's spreading. And that's the hard part. And how do you live with that? How do you interact in your daily life with your family, your friends, your coworkers? That's the big deal. And that's the important part that we as oncologists say, watch for waiting, go home. No, there's a whole host of things that happen when we leave.
Thank you much. I'm going to now turn to pain, which has been a really generates lots of questions in the EHE field. So a number of questions have come in related to pain. The first one you may or may not be able to answer it because I understand we're still trying to learn a lot about it. But the simple question, why is EHE so painful for so many patients?
I don't think so. We know exactly. But it is our clinical experience that some of the patients with EHE do not respond to a mainstream therapy for pain, including when they have a very, very microscopic disease that is not seen on the CT scan. Our experience has been that patients some of the patients will first point at their pain, and there is no disease, or there is no way for us yet to detect the disease, which I worry about the most, because our patient that we presented in our case study had that problem where she went through multiple evaluations and pain specialists and was told, this is in your head. It wasn't. So we don't understand completely why that pain is, but especially when it occurs in pleura, it causes a lot of pain.
Well, we did actually have a question come in on that topic and that you might be able to speak to. So someone was talking about a loved one who has stable disease, but is experiencing debilitating pain. And the question was, is that something we see with EHE? Is that a unique experience, or is that a commonality?
Again, I am not an expert in EHE, although I took care of patients with EHE. I'm more an expert in general, taking care of pain with serious illness. But that has been our experience, that it's not that you have to have an advanced metastatic disease in order to have pain. You may have a small amount of disease that we see on the scan or even during the surgery. So there is not a direct relation to amount of cancer that we see with our eyes with current science. And
I'll just follow up with that as well. It's frustrating to us as clinicians that try to treat this, and it's not unique. You do every single CT scan, MRI scan, and PET scan, and you can't really pinpoint where they are, but they're having a lot of pain in that area. And it's real. And this is the part that we see probably more than any other disease in the EHE patient.
Well, and related to that, are there common areas on where the pain is showing up? That was another question that came in. Curiosity about kind of regional, where is the pain showing up in EHE patients?
In my experience, it's liver and pleural space, but I don't know whether Kate and Scott, you have some other ideas, but the pleural space seem to be, when it comes to the lungs, seem to be very difficult first to identify and very difficult to treat as well.
Yeah, I find the pleural disease most challenging. And, you know, and for, I think, a number of different reasons. I mean, as you allude to, Dr. Vesel, you know, part of it is we just don't know. But, you know, I think part of it is the surgeries that people have performed on lung disease. You know, there's a lot of nerves in the intercostal space. And so there are some post-surgery syndromes that can lead to pain. And then just all of the nerve fibers that are, you know, underneath the ribs and in that region, you know, just are just a particular challenge. And going back to one of the members' earlier questions, you know, this is a place where, you know, if you may not have necessarily progressing disease, you know, you're doing scan serially and you're not seeing that progression, but it may be time to start a treatment to see if, along with pain medications, that can help control pain.
Then we also had a question talking about some additional categories of interventions for pain, and I'd love to hear your thoughts on this. This is largely due to now changes in some of the laws, making some compounds that were previously illegal legal. Specifically, cannabis was called out, and if you've had any thoughts about that generally or specifically related to EHE, but I would also open that up to any psychedelic drugs or other things that are undergoing sort of early trials at this stage.
It's an interesting question, and in my experience, that severe pleuritic pain, cannabinoids has not been very helpful. It's interesting because we actually did publish a patient case when we used everything. We didn't include cannabinoids in that, but the patient did use it. We didn't prescribe it, so that's why we didn't put it in the case study. But it was, in fact, Ketorolac that was surprisingly the most effective in her particular pain management. In my clinical experience in this particular disease, I would say cannabinoids and psychedelics has not been very helpful, or patient develop tolerance very quickly. For instance, they would respond for a week or two to, for instance, ketamine, but then over time, we would need to reach to the doses that would cause more side effects.
If I can just add one thing to that, and this is not necessarily specific to EHE, but just for all of the different sarcomas that I treat. You know, I agree 100% that I haven't seen, you know, the cannabinoids make that big of an impact in pain control overall. There's some exceptions to that rule, but I have seen it be helpful in actually some of the side effects of the pain medication. So, you know, some nausea, GI upset, you know, some of the, you know, anxiety of, you know, just being on a lot of medications. You know, I've seen some people use those kinds of things in concert with, you know, an integrative medicine specialist or a pain specialist in trying to manage some of those side effects. So that's something where I've seen them be very helpful.
Great comment. Thank you so much.
And kind of a question came in that feeds a little bit off of a point you just mentioned when we're talking about drugs that are being used. Are there any drugs that people are, or other interventions for EHE that itself might cause pain or cause other sort of disruptions, breathing problems that are something to take into consideration in thinking about the therapeutic approach and management of pain? And the question specifically, are the drugs are causing or contributing to the pain problem?
I haven't seen too many issues of that. Of course, traditionally there are some medications that will get used. And when I say medications, some of them are, chemotherapeutic or, targeted therapy types of things that can actually cause side effects like something called palmar-plantar erythrodysesthesia, which is a very long-winded fancy word for just your palms and your feet can hurt and have a lot of, neuropathic type pain. So in that way, some of the medications that we use can cause some pain. As far as the pain medications themselves causing pain, I haven't seen that in my experience, but I defer to my pain expert here.
And the question was directed more to the chemo and those, yeah.
Yeah, one of the things you have to think through is that docetaxel, or the brand name Taxotere, not to throw it under the bus there, it is known to cause pain in the areas where you have tumor. So we do coach individuals, if we do decide to use docetaxel, that you might get a flare of the pain after the infusion of docetaxel. Typically, we don't see that with other drugs that much, but it's something that you do see. Whether it's specific to EHE, probably not. It's just something in general that we do. But the vast majority of the drug therapies that we use rarely cause increased pain unless there is some inflammatory response. And when you get this inflammatory response, the tumor swells, pushes on nerves. The cancer is not growing. It's just that all these cells go in there and they cause a little bit of temporary pain. So you have to kind of just ride it out a little bit, because ultimately those inflammatory cells are going to then start to kill and destroy the tumor and shrink the tumor and then release some of that. So there might be this flare, at least initially.
I would like to mention back to the pain medications that yes, there are doses of medications when you escalate too high that the medication itself is toxic. And I think it's very important, what Katherine was mentioning is to have a multidisciplinary approach. So it's being noticed, since sometimes the prescriber is just continuing and doesn't realize this had been more than 6 months and you continue escalate, because then opioid rotation or bringing some other interventions are warranted instead of going up and up and up. And we are learning that from our patients who point out, I don't know, when I was on X amount, this was working, but when we went up, I'm in more pain instead of less pain. So it's a caution that our pain receptors get used to something and then they don't care anymore. It may actually cause harm. And then we may invite an agent that our pain receptors don't have a good memory of.
We've got one last question, and it's again on the topic of pain. One of the themes that has certainly come through on this is that we still need to learn a lot, and it relates to that question, and it's kind of two-part. What can you say about current research to understand more, either specifically on EHE or more generally on sarcomas or cancer? And are you aware of any clinical trials that are directed to pain management that the audience ought to be aware of that might have promise for the future?
There is a lot of research being done in multiple areas. I'm not aware at the moment of something, sparkling, but there are definitely there is definitely a clinical research looking some adjuncts that we didn't consider before. For instance, vitamin D for management of or adding to a pain management that's being done in Sweden, and definitely some other medications. They are not out there yet for the use in humans that are being tested. So my hope is that we will come up with other strategies than we just presented today soon.
I think one of the things that we're oftentimes seeing also, which I've really, even in my relatively short career of, 15 years or so, I've seen kind of get better as we go forward, is that a lot of clinical trials that are looking at cancer therapeutics will incorporate, quality of life measures as well. And, and some of the studies these days have gotten very sophisticated so that people will carry around beepers beepers, that ages me, pagers, or iPads where they can write down their pain, so that data isn't getting missed. And that can actually help with approvals of those drugs. So there has been a little bit more attention just in the, cancer therapeutic realm.
Excellent. That wraps up our time for this session. Really beneficial information. Thank you all for your contribution today.
Thank you.
Our next presenter speaking on the topic of liver transplant is going to be Andy Donnelly.
Hello. Can everyone see me? Oh, here we can. There we go. All right.
Video and audio are great.
All right. Thank you. Hello, everyone. My name is Andy Donnelly. I'm in Kansas City in the United States, and I am an EHE patient. I have been now for 21 years. I got diagnosed in December of 2000. So as a lot of patients do, I did some treatment, and the treatment was unsuccessful. Disappointing, yes. But then my doctor suggested I just kind of watch it for a while. I thought, oh, that sounds better than chemo. So we did that. And then about a year or so later, he started noticing a decline in my health. So he suggested something like a liver transplant. And I didn't know anything about liver transplants. So I kind of thought, why in the world would I do that? And then he explained it. He said, if you have a liver transplant, you might live a normal, healthy life, which sounded impossible to me. Well, I did have a transplant, and that was 18 years ago. And I've had almost perfect health since then. Haven't been in the hospital once overnight, but about a year ago, I got diagnosed with a recurrence. So I now have new tumor activity in my liver and in my neck and spine, and then a few kind of bone tumors here and there, about 10 or 15 of them, something like that. No reason for any of those, but here they are. So about a year ago, I started another chemo treatment, different than the first one. The first one was Taxol. The second one I just did, I don't remember the name of, but it didn't work. So we quit doing that in March. And he said, well, you're not feeling bad. I've never really had pain from any of this. So he said, well, how about we just watch it for a while and see what it does? So during all the scans I did a year ago, there was one tumor near my belly button that did show some growth. So we had that removed in May, and we sent that to a doctor in California in Long Beach to have some testing done on it. And they have come back suggesting that when I do start doing a treatment, that I start doing trabectedin. So once I start doing treatment, that's what I will probably be doing. So soon after the transplant, I was kind of looking for some new career moves. I had been in the alcohol business working for a distributor. And as a liver transplant recipient, of course, you don't drink. So I didn't want to really do that anymore. So I found a local nonprofit organization that I was familiar with. And they hired me to come in and start a mentoring program for transplant patients. So we literally started from scratch and developed and built a program. And over the course of 12, 13 years working there, we provided one-on-one mentoring services to people from all over the Kansas City area, and then later all over the country. We worked with people in like 27 different states for all kinds of transplants. I recruited, developed, and did an education class for the roughly 100 different transplant recipients, living donors, and caregivers we had on our roster. And so we mentored 800 patients over that time. And I personally mentored about 300 liver transplant patients. I ran across one person with the same type of cancer in those 300 patients I personally met with. She was in Nebraska, haven't heard from her in years, so I'm hoping that she's done as well as me. I've literally had a tremendous outcome. I don't feel any pain. I don't feel bad particularly. I had a transplant at 40, and later this year I turned 60. So Hoping for the best for this to continue to stay stable and not growing. That's about the best you can hope for, minus it mysteriously going away for no reason. So I'm happy to stick with the stable and not growing part. So life for me has been, an adjustment, but not a difficult adjustment. And, with what I'm dealing with now, still, I'm for the most part pain-free. I kind of attribute most of my aches and such to coming close to 60 years old. So the recurrence hasn't caused me a whole lot of problems. I did step down from my job to kind of focus on taking care of myself and spending as much time with my family as we can. I did become a father after the transplant. About 4 years later, my wife and I had a son who's now 15. So the transplant made that possible. It gave me a career I certainly didn't expect. And here I am 18 years later. I never dared to dream that I'd be here after that diagnosis 18, 20 years later. But here I am. And thanks to talented medical people like many of you, or all of you, people like me are still kicking, and we're grateful for that opportunity. So thank you very much.
Thank you very much as well. Our next presenter will be Dr. Rai.
Hello. Just a minute. Are you able to see my screen?
Yes, your audio is great and the screen is showing great.
Thank you. I'm Smriti. I am a physician trained in India and now in US pursuing a career in clinical research oncology. However, today I'm here not as a physician, not as a clinical researcher, but as a family and friend to the EHE community, and to help you guide on navigating through insurance coverage on your treatment options. Particularly, I will be talking about IRE management for hepatic EHE patients. Navigating insurance coverage is an, I would say, uphill battle for EHE, and definitely it is not so rare added complication for rare diseases. And the reason behind is that this rare diseases often they do not have any published or widely disseminated care guidelines that outline treatments needed to care for these patients. Therefore, patients and the caregivers, they need to spend time justifying their needed care components with the health insurance companies. Often they do so with the help of medical professionals, but it is not an easy task. So families with rare diseases, they end up fighting two battles. First, managing their disease, and then managing how to pay for it. Clinicians, they are often a huge support system for families living with rare diseases. However, I feel that clinicians can help us a little bit more on the macro level by working collaboratively to establish care guidelines and to write white papers, which can provide us to provide the insurance companies some additional documentation to help cover the treatments we need. Since yesterday, I'm seeing that there is our EHE researchers are working in that direction, and maybe very soon we will have a consensus paper, which we can then produce in front of the insurance companies and help ourselves get covered. Families can also be helpful in this situation. The families who are suffering with this rare disease, they have no other choice but to educate themselves on how to navigate through the system. Many times they do so without any guidance because they have no one who has traveled this path before. But yes, at one point, they do learn it on themselves because the setbacks are very costly to the family. They can't afford that. And those families who have learned how to navigate the system can then be guide to the other families in the disease community who are struggling the same. So I would say help can come here from clinicians as well as the families who have traveled the same path. Now, sharing here what I have learned about this whole process, that when a patient of an IRE, of hepatic EHE goes to a provider to have an IRE process, then the process starts from something called pre-certification or pre-authorization. And the code for that for IRE is 0600T. When the provider submits this to the insurance company, they most often get a statement saying that for participating providers, this service doesn't require medical pre-certification. Or they say that both facility and provider are participating in this insurance, so no authorization is needed. Often at times I've heard that even when the providers call the insurance company, they get the same answer that this CPT code is good to go. You are in network and no pre-certification is required. So I have known of patients who have taken this as good to go and have got IRE procedure performed, but then later the insurance company has denied to pay that claim, and bill worth of mid-$100,000 have been left on the table. Why did this happen? Because we didn't notice an alert on this pre-certification. There are statements on the pre-certification which say that please note that pre-certification information is not a guarantee of payment. For participating providers, this service does not require pre-certification. However, this may not be a covered benefit. So please take notice of this statements on your pre-certification. And what patients have done is that they have proceeded to the next step, and that is called predetermination. Predetermination is something that the provider, it is again the provider does it for the patients, but here they submit medical documentation to the insurance company's predetermination department to have something which is more, which can be more trusted. And it seems some medical person at the insurance company reviews that predetermination, and now this predetermination can be denied too. What happens after this predetermination is denied? Then the next step is peer-to-peer review, where the treating IRE provider will get on a call with the medical director from the insurance company and try to explain why the patient needs it. This has also been denied in case of many patients. After that, the patient has to go through the appeal process, which the patient can do or the provider can do for themselves. There is first level appeal, denied, we go for second level appeal. After second level appeal, for most of the insurance companies, the appeal system is exhausted. Now there are few paths that a patient can take. First is can request the insurance company to have an external review of the case, where the insurance company will send the documentation to an external, they call it independent reviewers, to review the case. However, at the same time, in parallel with the external review, the patient and the family themselves can also approach their state department of insurance and have them review this case. However, here, there is a point I would like to highlight, a new learning for myself and for through some other patients as well, that not every health plan is under the jurisdiction of State Department of Insurance. Some health plans are under the jurisdiction of US Department of Labor instead. And I will, in my next slide, I will go on to that one. Why so? We just know of a health plan as a health plan. We think that it is an insurance companies which are providing us those health plan. But many a times, insurance companies are just doing the administrative task. The health plan of that patient is actually being funded by their employer itself. And those are called self-funded or self-insured health plan, where the employer puts some money aside to take care of the health need of their employees. And they just hire a known insurance company to help them with the administrative tasks and to help them with processing of the claims. These self-funded or the self-insured health plans are the ones which do not come under the jurisdiction of the state departments of insurance. They come under US Department of Labor. And this is something that is, I can say it can cause a lot of anxiety if you know of this in the last minute, because the patient was thinking they are fighting against the insurance company, but what ends up is that they are fighting against their own employer. And in the susceptible situation that the patients are in, when they want to just somehow save their job, if you know that even for your insurance, you're dependent on the same employer, that's not a good feeling. So my suggestion in this case is that, having learned of this, that anyone who is going through, is navigating through their health plan to get a treatment covered, try to investigate this as early as possible. Try to ask your employer, try to ask your insurance company that, is your plan a self-dependent, funded or a self-insured health plan, and whose jurisdiction does it come under? Now, moving to the next slide, another thing that I would like to highlight here is that the flow that I shared in my previous slides, however, keeps changing. And these patients of IRE, they have to many times go through multiple sessions. And if you travel that path and somehow you succeeded in getting your insurance covered, and it will be only for one time, one session. Next time you will have to go through the same path again. And then next time when you're on that path, you will learn that the flow has changed. And I can say that how I learned this is that for one patient, the previous flow that I shared worked, but when they went on the same path the second time, they noticed that the predetermination for their insurance company can no longer be appealed. The insurance company told them that predetermination is a voluntary process and therefore cannot be appealed. However, you can again ask a re-review of predetermination, but you cannot go on the path of peer-to-peer first level appeal, second level appeal. And again, that is a devastating news, because then what do you do? According to the insurance company, you have to just take the pre-certification word and go for the process. And again, there is a possibility that the insurance company will deny. So what I'm trying to highlight here is that with every passing year, once you have gone through that track and you think you have worked and you know how to navigate it, next year when you will go to your insurance company for the same, you might find the flow has changed and you will have to learn the new ways. However, again, if this is a case with your insurance company, I'll say it is still better to go for a re-review, and hopefully in the re-review, they might approve of this coverage because they have previously done so, but that's not a guarantee. Now, and in fact, the most important part of my today's presentation is review packet. When you have reached the level of external review or the review by a state department of insurance, and if by US Department of Labor, what is very important is what is in your review packet. And here is my list of things that I suggest that should be a part of your review packet to make your case a real good solid case. Do write a personal letter. I will describe the contents later. Put in the review letter of medical necessity from the treating physicians, from your oncologist, from the IRE provider. If you have other treating physicians, or even if your oncologist is not very comfortable writing a letter of medical necessity, if they are comfortable writing a letter of recommendation, take that too and include it into your review packet. Include into the review packet all relevant medical records. That includes visiting notes from the oncologist, diagnostic pathology reports, labs, imaging reports, and not only imaging reports, but the images on discs. Try to educate the reviewers on EHE and IRE. Not many know of EHE and not many know of IRE. So do the research, write good notes on EHE and IRE and try to educate them on it. In this process, you can take help of URLs to videos on IRE, articles on IRE, articles on use of IRE for the treatment of hepatic EHE, and try to also share data on the number of EHE patients that have been treated and successfully treated worldwide by IRE. Personal letter, again, I have a whole list of things that can go in the personal letter, but I'll highlight the most important ones. Try to highlight in your personal letter that EHE is extremely rare And as only 40% of EHE patients actually have liver involvement, that makes hepatic EHE even more rare. Provide a summary of the patient's EHE history, treatments received so far, what were their outcomes, and if this is the second or third time of IRE session, then what was the result of the previous IRE sessions? Mostly it will be positive because you're then going for the other ones. List the medical experts consulted and their areas of expertise, especially sarcoma oncologists, interventional oncology radiologists, and if they are star EHE providers, do highlight that these are known names in the EHE field. List all the treatment options discussed, their benefits, risk, recovery time, long-time consequences, and how comparing them all. Your treating team, the patient, and the caregivers have finally decided that IRE might be the best approach to manage this patient's EHE at this current stage. You might also include cost benefit of IRE over other procedures, especially like over liver transplant. Highlight that IRE has received FDA clearance in the year of 2011, and it was for the surgical ablation of soft tissues. Note that not less than 21 HEHE patients in US have been successfully treated by IRE, and that was covered by the insurance providers. Mostly not in one go, but yes, it was covered either through appeals or through the intervention of government agencies. Read through your insurance policy. You will find something in your insurance policy that might help you. For example, patients have found that they have said this is experimental and investigational. Experimental and investigational will not be covered until it is a cancer. Use that sentence. Or if they say except under certain conditions, then try to make up a condition for this. Sometimes they say it will be covered only if it is under clinical trials. Then you can highlight and to say that it is so rare a condition that clinical trial of statistical significance is not possible. So in what you see in my slide in the red are the statements that can help you counter those statements in the policy. Demand someone qualified to be on the review team. Normally, it is a radiologist who reviews it. Ask them to have a sarcoma specialist on the review team, and if possible, an interventional radiologist. And demand options, just not denial. Just tell them that if you're saying no, tell us what do you recommend should be the treatment. What is your basis of saying that it will work in the EHE field? And what data do they have to say if that IRE was experimental, what they are suggesting is not experimental? And also, you might add personal effects to pull the heartstrings. I know of a patient who has a daughter in autism spectrum, and she used the sentence to say that if she goes for resection and transplant, she might not be able to take care of her daughter for months. And why should she go that route when there is a minimally invasive procedure available? If possible, and if applicable, apply your longevity to the insurance company or the employer. And again, these are some of the things I can think of. There might be more, but they will help make your personal letter strong. And with all this, I come to my last slide, and that is that if you have been through this, if you have traveled that path, if you learned how to run on that track, please help others. Share your experiences, guide. We are stronger together. Thank you.
And we have a video presentation. Some questions came in. What is IRE? Well, we're about to find out a lot of information about IRE. Dr. Kouvnadias is going to present.
Thank you, and good afternoon from Melbourne, Australia. Congratulations to the conference organisers for a great conference, and thank you for the opportunity to present our work on the treatment of hepatic or liver EHE with a novel tumour ablation procedure called Irreversible Electroporation, or IRE. We have no conflicts of interest to declare. Our research was approved by our hospital's ethics committee. We commenced our first safety study in 2008, and more recently, after being approached by the EHE community, we were granted approval to set up a registry with a name to roll this out internationally. I'm going to describe the liver disease pattern in HEHE and the advantages of IRE, which is a focal ablation procedure with very minimal side effects. And I'm also going to present the long-term outcomes of our HEHE patients. Our first patient, a 36-year-old female, had 11 tumours and had 8 procedures over 4 years between 2009 to 2013. At her most recent follow-up in 2020, 7 years after her last procedure, there was no disease recurrence. Our second patient, a 37-year-old female, had 7 tumours and 4 procedures over 18 months between 2004-05. And at her last follow-up, there was no recurrence in the treated areas, but there was 1 new suspected lesion which is being considered for treatment now. Our follow-up regime is with annual MRI imaging. We know that EHE is of vascular origin and that it can arise anywhere in the body. And a common site of disease is the liver. So what are the treatment options for HEHE? The surgical removal of tumours offers the best results. However, 80% of patients are not suitable because of the pattern of disease in the liver. And I'll describe that to you in detail on my next slide. Liver transplant is the most common and preferred treatment. The survival rates are good. The 5-year survival is reported to be between 55 to 73%. However, there are significant risks and side effects with organ transplantation, and there is a lifelong reliance on immunosuppressants. Also, with HEHE, there is a 30% recurrence of disease in the transplanted livers. Chemo, radio, and the more recent immune therapies are far less effective. So the presentation in the liver, on the right is a common recognizable diagram of the liver. For clinical purposes, the liver is described in segments, segment 1 through to segment 8. On the left is a schematic of these sections of the liver and the tumor pattern seen in HEHE. The yellow areas shown here are the tumors. This is a schematic of the pattern of disease in our first patient, patient A. So what we find are multiple tumours that are distributed peripherally around the liver, and they often coalesce to form large confluent regions like this tumour, tumour 1, which had a length of 8 centimetres. Also, the blood vessels in the liver taper and terminate at the edge of the tumours. And also often the tumours lie over vital bile ducts. So because of the multiple tumours and their proximity to the blood vessels and bile ducts, open surgical removal, which is the best option, is not possible in 80% of patients. So irreversible electroporation has a number of advantages. It is a focal tumor ablation technique that's effective for unresectable tumours. It kills tumour cells but spares the sensitive structures and connective tissue around the tumours. It has minimal side effects and a very quick recovery period. And very importantly, for disease patterns such as in HEHE, it can treat large tumours, and the procedure can be repeated to treat recurrence or any new lesions. I thought the best way to describe IRE was to show an animation. I have an industry animation that I hope will be useful and describe the process. So the IRE system comprises of a generator unit and needle electrodes. The electrodes are fine 18-gauge needles. 2 to 6 needles are placed in or around the tissue to be treated. The generator is then used to deliver a pulsated electrical current between the electrodes. The electrical field creates small holes in the tumor cell membranes, killing the tumor cells but preserving the surrounding tissue. The procedure is minimally invasive and is performed under general anesthesia with image guidance with either CT, as shown here, or with ultrasound. So the needles are passed through the skin, so you don't require open surgery, and the needles are positioned in the area to be treated. Once in place, the ablation treatment is delivered between the electrode pairs, and the electrical field between the electrodes is shown again here. The animation is showing the preserved blood vessels and blood flow, the nerves, bile ducts, and unaffected connective tissue around the treated tumor. The treatment can be repeated if needed, and depending on the size of the tumor, the needles may need to be repositioned to cover the whole area. After the procedure, we find a very clear demarcation between the treated and untreated area, so we can predefine the size of the ablation zone that we need to achieve. This is showing the individual tumor cells before and during treatment. The electrical field creates the holes in the membrane, the cells fragment and are removed by the body's normal physiological processes. The tumor fragments have also been shown to induce a positive immune response, and this is another area of interest and research with IRE currently. After the procedure, even small blood vessels are preserved, and over a 1 to 3 month period, the liver tissue heals. So here you can see the very small 1 millimeter blood vessels with blood flowing through them. So looking at safety of the procedure, technical success at the ablation site was achieved for all 18 tumours over 12 procedures, and there were no major complications. At one procedure, an electrode transversed the diaphragm, resulting in a small volume, clinically silent pneumothorax that was noted during the procedure. Technical challenges. The needle placement can be technically and anatomically difficult, adding significant time to the procedure. Ribs and other organs such as the bowel can make needle placement challenging. And this is because the needles need to be parallel and in line with each other to ensure that the required ablation area is achieved. And this can be difficult during the procedure. We would like to appeal to the manufacturer, to AngioDynamics, to please reintroduce the bipolar needles, which allow the energy to be delivered with just one needle, making the procedure a little bit more simple. In conclusion, IRE is a safe and effective treatment and is very suitable for the treatment of unresectable HEHE. Thank you very much.
Thank you as well. And we have a few follow-up questions specifically on IRE from the audience, if you wouldn't mind sticking around, Dr. Kouvnadias. First question is, does this procedure work or potentially work in other areas besides the liver? And specific questions about lung and pleura.
Yes, and thank you for your question. At our institution at the Alfred Hospital in Melbourne, we haven't treated other areas in EHE patients, only in the liver. However, IRE is suitable for any soft tissue, and it's really a matter of trying it out. And yeah, so we just haven't had the opportunity or referral for procedures outside of the liver. However, we have treated other cancers, like in the kidney, and we have done other areas as well. And IRE has been tried in the breast, in bone and other areas, but these are still areas of research.
Then we have a few questions comparing this to alternative ablation procedures. Some of the patients who are on the line here have actually had some other procedures. So one specifically comparing to like radiofrequency ablation, which patients experience a bit of pain. Can you comment on whether that you can make some comparison on differences in pain or recovery related to IRE relative to radiofrequency ablation?
Yes, the distinction between IRE and the other ablation techniques like radiofrequency ablation, microwave, and even cryoablation is that it's non-thermal. So you don't actually have that destruction of the tissue around, and also then the healing process that's required around the tumor. It's different. And this is why some of the other ablation techniques like RFA and microwave aren't suitable, similarly to resection. And this is because the blood vessels in the proximity of the area just don't allow, and other vital structures preclude the other ablation techniques to be used. Whereas with IRE, because it doesn't affect the vital structures, it can be used to treat those lesions. So you can put the other ablation techniques, the thermal and cryoablation techniques, in the same category as open surgical removal. So it's the same situation as to what is resectable and what isn't with that group of procedures, whereas IRE offers that advantage of not affecting the vital structures and can therefore be used for that purpose.
One last question that came in related to procedure risk. Is there any risk with this procedure of when the needles are being withdrawn of populating cancer cells in the pathway on the way out?
Look, seeding is an issue, even when doing biopsy. However, because you are killing the tissue around the needles, I think it's quite a minimal problem, and we haven't actually seen that. Or we can't actually say that we have seeded tumor in other areas of organs that we have treated. And at our centre, we have treated almost 200 patients or more with IRE in mostly the liver, but also in the kidney, but we have not seen any sort of seeding effect.
Thank you so much for your time today.
So, pleasure.
Super interesting presentation and a nice new option available to patients coming online here. Thank you so much.
Thank you.